in future when you get a case like this, how exactly you have to tackle the case. So I welcome Ashish to start the presentation. Ashish, please.
Thank you, madam.
You can share your screen and show the slides. Okay, that's it. Good.
Good evening, madam. Good evening, teachers and friends. Today I am presenting my case. My patient is a 23 years male from Tamil Nadu. Informant being the father and patient himself came to our OPD with chief complaints of breathlessness on exertion for last 2 years. One second. What is coming?
No, it's okay. Go ahead.
Madam, history of present illness. He was apparently asymptomatic 2 years before. To start with, he developed breathlessness on running and climbing stairs for last 2 years, which is gradually progressing. Now he feels breathless on climbing 2 flights of stairs. He is on NIHA class 2.
Okay.
There is no history of easy fatiguity, dizziness, syncope, chest pain, orthopnea, PND, or cyanosis.
Okay, that's all?
No, madam.
Okay, go ahead.
The patient has a significant past history. So I would like to elaborate the past history also. He is the second child of non-consanguineous parents, born at term by normal vaginal delivery. Mother noticed feeding difficulty, fast breathing during rest, which was more during feeding from 2 months of age. He had one episode of cough and cold at 3 months of age, for which the parents consulted a pediatrician. The pediatrician, after evaluation, told the parents that the baby is having some abnormal heart sounds, and subsequently he was referred to a cardiologist. He was evaluated in triple M, and the parents are told that the baby is having heart defect from birth and needs multiple surgery.
Okay.
Parents did not notice any bluish discoloration in the child during these 3 months.
Okay.
He underwent fast operation at the age of 3 months through a midline incision. The post-operative period was uneventful. Parents noticed improvement in the symptoms like feeding difficulty is better now. His feed is better now, and after the surgery with adequate weight gain. He underwent second surgery at the age of 1 year through a midline incision. The post-operative period is also uneventful, and he was discharged from hospital on 8th day of surgery. He was relatively asymptomatic after the second surgery. However, as he grew and became more active, he complained of breathlessness on playing and physical activity, which was gradually progressive. At that time also, parents did not notice any bluish discoloration as the child grew. He underwent the third surgery again through midline sternotomy at the age of 11 years. After the operation, the symptoms improved, and he was relatively asymptomatic with normal play and activity till last 2 years. Birth history: second child, term, normal vaginal delivery, cried immediately after birth, no NICU stay. Father didn't know actual the weight of birth weight. Developmental history: there is no developmental delay. Treatment history: he was not on prolonged medication after first and second operation. He was started on warfarin after third operation, and it was stopped after 4 years due to one episode of blood vomiting, and started on ecospin. This medicine name, madam, told by the patient himself. He underwent one procedure from groin 6 months back for the present symptoms, and he had right groin swelling and discoloration after the procedure, which was managed conservatively. There was no improvement in symptoms after the procedure.
Okay.
After this groin procedure, madam.
Okay.
Family history: he has one sibling. No family history of any congenital heart disease or sudden death.
Okay.
Socioeconomic history: he is a bachelor in visual communication. Father is a farmer. He belongs to a lower middle socioeconomic class according to modified Kopusami scale.
Okay.
Personal history: normal appetite, no addiction. Bowel and bladder habits are normal.
Okay, shall we go back to the first slide, Ashish?
Yes, madam.
We'll come systematically one by one. This is 23 years old person. That means he has grown well.
Yes, madam.
Only complaint is he has got exertional dyspnea.
Yes,
Now,
ma'am.
can you explain to me or to the students what is the mechanism of exertional dyspnea and when do you get it? What are the conditions?
Madam, exertional dyspnea when anyone does exertion, there will be increased body demand, increased body demand of oxygen. So, during the exertion or exercise, there is increase in both heart rate and cardiac output. So that will in normal person that will maintain the required oxygen demand.
Okay, Ashish, we put it this way. The exertional dyspnea could be respiratory or cardiac.
Yes, madam.
We'll leave the respiratory, we'll think of the cardiac. In cardiac, wherever there is a demand to supply mismatch, due to the fixed cardiac output, you can have exertional dyspnea.
Yes, madam.
That means whenever the person exerts, normally also after heavy exercise they become breathless. But here, for even slight exercise they become. He's in adventure class 2. So that means the demand to supply mismatch is there. So the breathlessness. The second mechanism is when there is a left-sided heart disease, LVDP is raised, LA pressure is raised, and pulmonary venous pressure is more, and there is an interstitial edema. That time the lung becomes turgid,
Congested.
it loses its elasticity, and the J receptors are stimulated. Herring-Brewer reflex comes into action, and they become breathless.
Yes,
So this worsens with the exercise. The third mechanism is suppose they have any right-sided obstructive lesions where the pulmonary flow is reduced, then also they will have exertional dyspnea because of decreased flow. And invariably, this decreased flow situation on the right side, that the pulmonary flow, will be associated with the cyanosis. But repeatedly, you kept on telling that there was no cyanosis noticed. However, last time we discussed anything above 85% may not be visible. So there may be desaturation, but it is not visible to the person. So
Yes,
we do not know about the saturation at this stage. So here with the exertional dyspnea, we don't know whether it is pericardial disease, RVOT obstruction, LVOT obstruction, or any structural defect or the left-sided heart disease. We do not know about it. Okay, go to the next one. However, you said there is no PND and PND. So that means when there is no paroxysmal nocturnal dyspnea, you can say that probably the mitral valve disease is unlikely. Okay?
Yes, ma'am.
That's what we can conclude. Go to the next. So here, the mother noticed feeding difficulty. So what do you think of the feeding difficulty?
Feeding difficulty means, madam, he was not able to suck continuously.
No, you say the mother has noticed suck rest suck cycle.
Yes, ma'am.
So suck rest suck cycle indicates that there is a LV dysfunction.
Yes, ma'am.
Or there is a left-sided problem and that has caused. So along with that, you must ask whether the child also had excessive sweating.
Yes, ma'am.
So excessive sweating with suck rest suck cycle indicates left-sided heart disease with the left dysfunction, left ventricular dysfunction. Okay, but the patient was admitted once for the lower respiratory infection. So lower respiratory infection could be due to the large left to right shunt with the increased flow to the pulmonary artery. So at this stage, we do not know about that. Okay.
Yes,
then he was evaluated when he was very young, and he was told that there is a need for multiple surgery. So once in a triple M, the advice is given that it requires multiple thing, that means it is not a simple VST, simple AST, simple PDA. So simple congenital heart diseases are unlikely.
Yes, madam.
They may be there as a part of the complex lesion, but it is not a isolated single lesion. Okay, so anything requiring multiple surgery means it is a complex congenital heart disease. Most often complex congenital heart diseases are cyanotic, but here the child is not cyanotic. The reason could be two. Before the cyanosis became worse, maybe the palliative surgery has been done, and that's why the cyanosis didn't become obvious. That is one possibility. Or probably it is, though it is a complex, it is not a cyanotic heart disease. One of the two things. Then you said the baby has undergone surgery, and go to the next slide. Next slide, please. So here the child underwent surgery at the age of 3 months. That means if they have done at the age of 3 months, it must be a palliative surgery. But you said it is with the midline incision. So what could be the possibilities, you tell me?
Yes, madam. As the child was having increased symptoms of increased pulmonary blood flow, and the palliative procedure was done through midline incision, so it was most probably a pulmonary artery bending, madam.
Okay. See, most often for the decreased pulmonary flow, the BT shunts are done by the
Right.
side the incision, not the midline incision. So if the midline incision is taken, it is invariably very small children, very small pulmonary arteries, where you are connecting the shunt to the middle, that is the main pulmonary artery, then the midline incision is taken. So here, because we had the history of left-sided heart disease, suck cycle, and also the symptoms of left-sided lesion, we think there is a large left-right shunt because the child was admitted. So probably to prevent the pulmonary hypertension, the pulmonary banding was done in time. Now, compared to the last time's case where the first doctor missed the diagnosis, and as a result, it was too late for the pulmonary banding by the time the diagnosis was made. Here, I must compliment that the parents as well as the attending doctors have taken action in time. Within 3 months, the palliative surgery is done. Most probably, it is a pulmonary banding because the symptoms suggest that it is a large left-right shunt. Okay, the next one. He underwent second surgery at the age of 1 year. Again, through the midline incision, what could be the possibility? Surgery.
Yes, madam. As it was done at the age of 1 year, so we are thinking of a complex congenital heart disease. It could be a like corrective surgery after the first palliation, or it could be a second palliation also, like a right side, means a Glenn shunt.
Correct. We have to keep both in mind.
Yes, madam.
Because initially the parents were advised it requires multiple surgeries. Okay. Multiple means more than 2.
One. Yes, madam.
So in that direction, this could be again another palliative surgery or partial correction. Because if it is a complete correction, there is no need for the third surgery. Okay, because third surgery is done at the age of 11 years. That means whatever is done at the age of 1 year is either another palliative surgery or it could be a partial correction of the complex congenital heart disease. That's what we can think of. And then he was discharged on the 8th day. That means it was absolutely fine and the child was all right. Okay, then go ahead. He underwent the third surgery again through the midline sternotomy at the age of 11 years. So what do you think at this stage?
This was, madam, the final palliation, madam.
No,
or
this
a,
is not
or a
considered
total operation.
palliation. It is a corrective surgery.
Corrective surgery.
The first one is palliation. The second one is palliation, or it could be
Partial
partial correction. And now it is either total correction. Okay.
Yes, madam.
So the third one must be a total correction. So this is what we think. And then after operation, the child was all right, completely normal for the next 2 years. So from 11 years to almost 21 years of age, the child, he grew well. And then we will see when we come to the parameters, how well the child has grown, we'll think of that. So till now, this is the thing. Go to the next one. So birth is almost insignificant, because no NICU means it is not a duct dependent condition.
Yes, madam.
If it was a duct dependent condition, complex lesion, then the child would have required admission to the NICU. So this was not a duct dependent. Okay, then in the development history, there is no development delay because the correction palliation was done in time, and as a result, there is no restriction to the growth. Okay. Then in the treatment history,
There is no prolonged medication after first and second operation.
See, prolonged medication invariably is given when there is either right-sided or left-sided failure, and for the decongestion, the drugs are given, or where there is a decreased flow and to improve, the Indirol is given. So we are not thinking in terms of both of them. Okay,
then he was started on warfarin after third operation, madam.
Yes, that is important. If the warfarin is started and then followed by ecosprin, what do you think is the possibility?
Madam, it is the third operation was a Fontan completion, after which the anticoagulation was started.
You can say, instead of Fontan, you can say probably there is a conduit, and to prevent the obstruction in the conduit or thrombosis and the thromboembolic episodes, the warfarin was started. Okay, yes, and that's how you can think of that. Okay,
then madam, he underwent one procedure from groin 6 months back, madam.
Okay, what do you think that procedure is?
Madam, because of these symptoms for last 2 years, he was on a regular follow-up.
Now, you can think of two things.
Yes, madam.
Either it is a catheterization,
or is it therapeutic?
To assess any shunt or leak or anything, or to correct if there is some baffle leak or something is there, some sort of problem is there, to correct that. So yes, one of the two things are done with the in the groin. So whatever the local complication that he has gone is can occur with any sort of procedure, either with the procedure or catheterization, the hematoma can occur. So the groin complication is a local problem, and that too because the patient was on already warfarin and ecosprin, that could have happened. Okay, yes, so that's all we can assess with this. Now you analyze the whole thing that we have, then summarize it, and then you tell me what you suspect.
Yes, madam. Madam, summarizing the history, 23 years male with a complaint of dyspnea on exertion NIHA class 2 now, with a past history of feeding difficult, means a Socrates cycle, forward sweating and fast breathing from 2 months of age, and one episode of respiratory tract at 3 months of age. On evaluation, told to have some congenital heart disease which require multiple surgery. Underwent 3 surgeries at 3 months, 1 year and 11 years of age. Post third operation on warfarin followed by ecosprin, and after that he was late lesson 20 status up to 21 years of age. So I am thinking like, madam, it's a complex congenital heart disease with increased pulmonary blood flow. Can be cyanotic, acyanotic, madam. I can't differentiate it from the history. Okay. There are 3 palliations at 3 months, 1 year of 11 years of age. Now in NIHA class 2, maybe due to ventricular dysfunction or ventricular dysfunction due to AV valve regurgitation or semilunar valve regurgitation or semilunar valve obstruction also. So my differential diagnosis in cyanotic heart disease will be tricuspid atresia with VSD with increased pulmonary blood flow. Because it's a three surgeries with univentricular history looks like a univentricular palliation. So DORB with heavy valve styling or one of the ventricle is hypoplastic or single ventricle with increased pulmonary blood flow. These are my differential diagnosis in cyanotic, and in acyanotic, unbalanced AV canal defect can be a possibility, madam.
Okay, we'll come by one. All the time there was no cyanosis, you said.
Yes, madam.
So why you want to bring the tricuspid atresia first? In the history I'm telling. See,
Yes, ma'am.
The history is the left-sided heart disease because the child had the suck cycle and also the respiratory infection requiring admission. So underwent the palliative surgery. So you have to think something like the left-sided heart disease. Of course, in tricuspid atresia also it is the LV.
Yes, madam.
DORV does not come because there is nothing suggestive of right-sided heart disease at that time. Okay,
Yes,
so
ma'am.
unbalanced AV canal defect is a possibility. So in AV canal defect, they develop pulmonary hypertension fast, especially if they are associated with the Down syndrome. Nearly 40 to 50% of the AV canal defect, they have associated Down syndrome. So that could be a possibility. But in AV canal defect, you don't have multiple surgeries. You can have pulmonary banding one and then total correction again. Okay, you don't go for the third. So requiring three surgeries are the first thing that we think in terms of the tricuspid atresia or pulmonary atresia. Whenever there is an atresia, they require the multiple surgeries. So those are the possibilities. Okay.
Yes, madam.
So since it is a complex congenital, we can only suspect and think of the differential diagnosis, but we cannot tell what it is because this is a really complex and it has been operated so many times, and any intervention, it alters the whole natural history of the case. And as a result, we are not able to make specific diagnosis like this could be the first diagnosis, this could be the second, this is the third possibility. We are not able to tell those things. So we will keep AV canal defect with the pulmonary hypertension and also the tricuspid atresia or pulmonary atresia as a possibility. But if it is a pulmonary atresia, the midline incision, whatever the palliation was done, it could be something like a pot surgery or something where the shunt is to the main pulmonary artery. Otherwise, it is not through the midline. Okay, so that's the reason we keep it as a last possibility. Okay.
Madam, tricuspid atresia with increased pulmonary blood flow, madam, not decreased pulmonary blood flow, madam. My diagnosis is tricuspid atresia with VSD with.
It could be both.
Yes, madam.
If it was with decreased pulmonary flow, then cyanosis would have been obvious.
Yes, madam.
Because of the increased pulmonary flow, we have had the respiratory infection, we had the suck cycle. So we think it is probably the increased blood flow rather than decreased. But however, on examination and with investigations, our diagnosis may be different. But
Yes,
at
madam.
present, analyzing whatever the patient has told or the father has told, we think that it is probably left-sided heart disease involving the left ventricle and then the increased pulmonary flow and requiring the multiple stage surgery. So the first one could be like a banding. The second could be like a partial thing like, connection of the SVC to the thing like the bidirectional gland. Or third could be due to the total correction, like a TCPC or anything. At this stage, we cannot guess because all that can be made out only by the investigation and the examination. Even at the examination, we may not be able to conclude because this is a complex congenital. Okay?
Okay.
Go ahead.
Should I go to madam examination?
Go ahead. if anybody has got any questions, you please start asking in the chat box so that we can answer then and there only. Okay, go ahead.
On examination, he is well built, conscious, cooperative, well oriented to time, place, and person. Weight is 58 kgs. Height is 175 centimeter. BMI is 8.9 kg per meter square, which is normal. JVP is visible 2 centimeter above the clavicle in 45 degrees, non-pulsatile. With pressure in the right hypochondrium, there is no elevation of JVP. No pallor, icterus, cyanosis, clubbing, pedal edema, or lymph node.
There is no hepatojugular reflux is not there.
Yes, madam.
Okay, fine.
There is no kyphoscoliosis. There is no peripheral signs of infective endocarditis or aortic regurgitation.
Good.
He is afebrile. Pulse rate is 70 per minute, regular, normal volume and character. All peripheral pulses are well felt. There is no radioradial or radiofemoral delay present.
Okay.
Respiratory rate is 18 per minute, regular. Blood pressure in right upper limb is 120 by 80 millimeters of mercury. Right lower limb is 110 systolic palpable. Right lower limb is 120 systolic palpable.
Okay, so everything, the respiratory rate, pulse rate, the temperature, the blood pressure are all right. But the fifth parameter, that is the saturation, is slow. It is low.
Yes, madam. 19% improvement.
Definitely reduced. So
Yes,
normally it is above 95, and anything below 93, we take it as a desaturation. So between 85% to the 93%, we may not see the cyanosis, obvious cyanosis. But however, 91 is definitely low in the roommate.
Yes, madam.
Okay, that means whatever correction has been done, either it is not complete, or even if it is complete, maybe there is some sort of mixing occurring at some stage or the other. Okay.
Yes, madam. Yes, madam.
Go ahead.
On cardiovascular system examination, madam.
Somebody has asked a question. Vaibhav has asked, can we comment on the JVP post-Glenn?
Yes, madam. We can comment on JVP, madam. Because if the gland pressure is high, JVP will be raised. But it will be not. If there is no antegrade flow, then there will be it will be non-pulsatile, but it will be engorged, madam.
See, invariably, Glenn is done when the PA pressure is normal, and
Yes, madam.
as a result, JVP will not be raised. But when there is a complication and the pH occurs, at that time the JVP can be raised. Okay.
Yes, madam.
And at the time of examination, we don't know whether Glenn is done or not.
Yes, madam. Yes.
So to complete our examination and to present, we have to mention about the JVP. Okay.
Okay,
I think we have clarified your doubt. Okay, go ahead.
On cardiovascular system examination, madam, inspection, midline sternotomy scar is present. Scars in both sides of the chest and the epigastrium. Mild left precordial bulge is present. No visible veins, no visible pulsation in suprasternal notch. Apical impulse is visible in left precordium. Palpation trachea is central in position. Apex beat is palpable in left fifth intercostal space, 1 cm medial to the midclavicular line. Forceful, well sustained with medial retraction. Systolic thrill present in left third intercostal space. No parasternal heave, no palpable second heart sound, and no palpable S3 or S4 or carotid thrill. No epigastric pulsation present, madam. Percussion, right heart border is retrosternal, left heart border corresponds to the apex, left second intercostal space resonant, liver dullness starts from right fifth intercostal space, stomach tympani on left side. On auscultation, S1 is normal, S2 is single, soft A2. A grade 4 by 6 crescendo descendo high pitched long isosystolic murmur is best heard at the left third parasternal area with the diaphragm stethoscope with expiration and leaning forward. The murmur is heard all over the precordium with decreased intensity. A grade 2 by 4 high pitched decrescendo early diastolic murmur is best heard at the left third parasternal area. The intensity of murmur increases with hand grip. Okay. There is no additional murmur heard in the any precordium or back. There is no click or no added sound is heard, madam.
Okay. So go back to the previous slide where you started the examination. Okay, here. Midline incision scar that corresponds to the history that we have taken.
Yes, madam.
And then the mild left precordial bulge is there.
Yes,
What does it indicate? Precordial bulge, what does it indicate?
it indicates, madam, there is a chronic heart condition which has caused some mild precordial bulge.
Now, here in this patient, that precordial bulge could be because of the repeated surgeries.
Okay, madam.
The deformity could be there as a post-surgical complication, one thing, or because we suspected left-sided heart disease, whenever the left ventricle is enlarged, the left atrium also gets enlarged. And it is the left atrium which is between the sternum and the sternum in front and then vertebral column at the back. So when there is the left atrial enlargement is there, the soft sternum, which is made up of cartilaginous bone, it protrudes. So the precordial bulge, in this case, it could be due to the post-surgical or it could be due to the left atrial enlargement. So that is the two possibilities. When we do the echo, we will see whether the left atrium is enlarged or not. Okay. Then in palpation, you said there is a systolic thrill in the left third intercostal space. What do you think of it?
Madam, it is a systolic thrill, so it could be a, and in history we have seen that there might be a univentricular palliation, so it might be a systolic thrill due to aortic obstruction, but it is best palpable in the left third intercostal space, madam. So maybe because of subaortic obstruction.
Okay. One thing everybody should remember is you get thrill whenever there is an obstruction. At the base of the heart, if you get a thrill, it is either due to the aortic stenosis or the pulmonary stenosis. If you get a thrill in the apex, invariably it is the diastolic thrill because of the mitral stenosis. So here, a residual VST
Yes, madam.
can cause a thrill, or a pulmonary stenosis can cause a thrill, or aortic stenosis also can cause a thrill. Now, any either LVOT obstruction or RVOT obstruction or a VST, all three of them can give rise to the thrill. So at this stage, with the thrill alone, we cannot make out what it is. Then apical impulse is one space, it is in the fifth intercostal space and medial to the mid-clavicular line. That means the ventricular hypertrophy or the volume overload is not there. And it is forceful and well sustained. Once it is forceful and well sustained, it indicates that there is a LVOT obstruction. So LVOT obstruction causing the LV hypertrophy. So LV hypertrophy can occur with the subaortic obstruction, valvar obstruction, or supravalvar obstruction, or with the coarctation. So these are the LVOT obstruction that give rise to the LV hypertrophy causing the heaving apical impulse. But here we have no symptoms of coarctation. The pulses in the lower limbs are normal, BP normal, so we don't think of that. And if it was a supravalvar aortic stenosis, the pulse as well as the blood pressure in the right and the left upper limb would have been different. Because of the tangential flow, right upper limb pulse as well as the pressure will be higher than the left, more than 10 millimeters of mercury. And that is called as the quandary. So the shudder will be there. So that is not there. So we rule out that also. So no coarctation, no supraaortic stenosis. Valvar stenosis quite possible because the thrill and the murmur are heard in the herbs area. That is the new aortic area and not in the pulmonary area. And as a result, it could be an associated aortic stenosis. And to support that, the aortic component is muffled, you said.
Yes, madam.
Invariably, when there is a single second sound, the aortic component will be loud or pulmonary component will be loud. But invariably, when aortic component is muffled and it is single, how do you analyze that symptom, that examination finding, physical finding?
Yes, no, it is usually when A2 will be there, it will be uh, it will be equivalent to the S1. It is
Okay,
not.
I will explain to you. See, the split second sound is due to the hangout interval, right?
Yes, madam.
So when the hangout interval is more in the RVOT obstruction, there is a wide split and the pulmonary component is muffled. But when there is a LVOT obstruction, A2 moves away. So A2P2 becomes closer, and as a result, for your ears, they are heard as a single second sound. It is not a true single second sound. The split between the A2P2 is so narrow, less than 30 milliseconds, and as a result, you hear it as a single second sound. And because there is an aortic stenosis, the A2 will be muffled. So with this findings, we can think that there could be a significant aortic stenosis, and as a result, the A2 has moved and A2, P2 are occurring almost like a simultaneously, and A2 is muffled. But you said there is no ejection click, no S3, no S4. And carotid thrill, is the ejection systolic murmur conducted to the carotid or not?
No, no, madam.
If it is not conducted to the carotid, then we can't think in terms of aortic stenosis. Because any aortic stenosis, because of the contiguity, that means aortic valve to the ascending aorta to the carotid, it is the anatomical contiguity is there. And as a result, any murmur originating in the valve is conducted to the carotid. So here, so we don't know what is the cause for the ejection systolic murmur in the third space now. Okay, then.
And there is a early diastolic murmur grade 2, madam.
Okay. Early diastolic murmur grade 2 is there. So what do you think of that?
Madam, it may be associated with the AS may be associated with the AR, aortic regurgitation, madam.
If it is associated with AR, your pulse should be collapsing and your BP pulse pressure must be wide. So we felt that the pulse is normal, you said, and then the blood pressure also you said normal. You go back and see what was the thing. Okay, somebody is asking, does subvalvular obstruction also radiate to the carotid? No. If there is a subaortic membrane causing the thrill and the murmur, that will not be conducted to the carotid. So that is a very good valid point, well taken. Okay. So you tell me what was the blood pressure?
120 by 80, madam.
Yeah, 120 by 80 is a normal one.
Yes,
If
madam.
pulse pressure is more than 40, then we take it as a runoff. Okay. So 120 by 80 is absolutely normal, no?
Yes, madam.
And the pulse, you said regular, normal volume, normal character, and all peripheral pulse normal. So it is unlikely to be a valvular stenosis. If it is valvular stenosis, it has to be conducted to the carotid. Okay. So we don't know. And this early diastolic murmur could be originating from the pulmonary valve, or it could be a mild aortic regurgitation without causing the peripheral signs. One of the two things.
Yes, madam.
Okay.
Madam, other system examination normal, madam.
Okay.
So summary of findings, madam.
Okay.
Well-built boy with a saturation of 91% in room air, with midline sonotomy scar, mild left precordial bulge, forceful well-sustained apex, systolic thrill in left third parasternal area, single soft A2, grade 4/6 high pitched ejection systolic murmur, best heard in expression and leaning forward.
No,
Grade
I
2.
think something is wrong here. Whenever the regurgitant murmurs are high pitched and soft and blowing, like aortic regurgitation, mitral regurgitation, they are all high pitched.
Yes, madam.
But when you say ejection systolic murmur, they arise either from the semilunar valve or obstruction below that, like the infundibular stenosis or subvalvular membrane, and there it is rough. Okay, it is harsh. So remember, all obstructive lesions, the murmurs are harsh. Regurgitant murmurs are soft and blowing and high pitched. Okay, go ahead.
Okay, madam. Grade 2/4 is early diastolic murmur with increased intensity of the hand grip. Both the murmurs in left third parasternal area without cardiomegaly.
Okay. Yeah, one question is here. Subaortic membrane causing mild AR, is it possible to consider? Yes, definitely possible. Then there will be a to and fro murmur. To murmur is because of the subaortic membrane. Fro murmur is early diastolic is due to the membrane. Whenever there is a subaortic membrane, there will be damage to the aortic valve, and as a result, it causes the aortic regurgitation. So at this stage, that possibility must be kept in your mind, because when you are doing the echo, you have to look for the subaortic membrane, because the subaortic membrane is so close to the aortic valve, unless it is there in your mind, you may not see. There are three grades of subaortic membrane. A small thin membrane can be missed if your mind is not thinking of that. So that possibility has to be kept in mind. Rohit, I agree with that point. Well taken. Okay. Go ahead.
So my provisional diagnosis, madam, situs solitus livocardia, congenital.
No, Ashish. Always tell the congenital, cyanotic or acyanotic heart disease first. Then come to the situs. Then come to the livocardia. Then come to the anatomical. Then the physiological. Then complications, and then conclude. Okay.
Yes,
So
madam.
tell congenital.
Congenital cyanotic heart disease with increased pulmonary blood flow, situs solitus, livocardia, status post univentricular palliation, most probably a fenestrated fontan completion with a severe aortic stenosis and mild aortic regurgitation. Now in NIH class 2 in sinus rhythm, not in heart failure, without features of infective endocarditis.
Okay. The examiner might ask you, why do you call it a cyanotic?
Yes, madam, it's a complex congenital heart disease. Still, acyanotic is a possibility.
Because the saturation is 91 despite the surgery.
Yes, madam.
So it has to be cyanotic. Okay. That's how you have to answer. Okay. Then univentricle or what, we don't know, we cannot tell. That we can decide only after our echo interrogation. Okay. So because the three surgeries are done and we are not thinking in terms of this not fitting into the pulmonary atresia or any other condition, and we all the time thought of the left-sided heart disease, possibly it is a fontan. Okay. And now in sinus rhythm, no evidence of endocarditis, not in failure. Perfect. Okay. What is the second diagnosis? The differential diagnosis?
Madam, differential diagnosis will be, madam, like all.
Sanmesh is asking, with the history wise, can you rule out the TGA physiology? The TGA physiology cannot be ruled out, but invariably the TGAs are like a duct dependent, and they become cyanotic and they become worse in the neonatal period itself. So we decided that the child did not have NICU admission, so it is unlikely. And in case of TGA, if there is a large VST, they can have thing, but that possibility we did not think because there is no cyanosis at any time. Okay. Okay. Next.
Madam, my second difference diagnosis will be it's a biventricular repair with a residual BSD residual BSD with a severe RBOT obstruction which is causing right to left shunting and mild decrease in cyanosis also.
And since the pulmonary banding is done with thought because of the pulmonary flow, and that early regurgitation could be due to the pulmonary regurgitation also.
Yes, madam.
We don't know. So here, without echocardiography in such complex congenitals, we cannot dogmatically tell it is AR because the peripheral signs are not there. We cannot, we can say that it could be PR. After doing the echo, we may see an AR. That's a different issue. But here, it could be PR, it could be AR. Both can be possible. Okay. Yeah, go ahead.
Madam, investigation? Madam, investigation will be shown by Dr. Jisan, madam, one of my colleagues.
Okay. Yeah, please. You want the ECG or the X-ray first?
Madam, ECG first, madam.
Okay. Get the ECG. You can show the ECG.
I am being disabled. I'm not being able to share screen.
Amitabh sir, you have to allow Jisan sir to share the screen, sir.
Amitabh, ask Jishan to show the ECG and the X-ray and the investigations.
I'm not being allowed. Ma'am, I'm not. Hello? Yeah, I'm not being able to share screen. I'm echoing.
And Rohit Raj is asking, increasing with the hand grip, it means AR. Yes, with the dynamic auscultation, it could be that. Did you mention that the increasing with the hand grip? But invariably, moderate to severe aortic regurgitation, they will have peripheral signs. If it is a mild AR, which is increased with the dynamic auscultation like the hand grip, that means it could be mild to moderate AR. So that possibility cannot be ruled out. So in the examination, we cannot dogmatically definitely tell it is AR or it is PR. No, first show the ECG. Show the ECG first. Okay. Okay. Make it full screen and read it. Okay, excellent. Okay, read the ECG, Ashish.
It's a 12-lead ECG, madam.
Okay.
With normal standardization and speed of 25 millimeter per second. Sinus rhythm, madam.
Okay.
P axis is around.
See, normally in V1,
Yes,
we
madam.
get the biphasic P wave.
Yes, madam.
What is here?
Here is only RA component is there, madam.
LA is more.
Yes.
LA contour is more. The negative is more.
Okay, madam.
And we had a precordial bulge also. And then there is an RVH. How many millimeters? Not much RVH, no?
5, 10, 15, 15, madam, in V1.
This is V1 or okay. 15 is RVH.
Yes, madam.
Definitely it is an RVH. So what are the criteria to call it as RVH?
Madam, in V1, R by S more than 1.
Okay.
Or in ABL, it is more than 11 millimeter, madam.
Okay.
And deep S waves in V6, madam.
And the STT changes.
STD changes, madam.
RVH with the strain pattern.
Yes, T inversion in 7.
That in V1, V2, you have the ST depression with the T wave inversion.
Yes,
so there is a RVH with the strain pattern. So RVH with the strain pattern could be due to the pulmonary hypertension, And then what else? What's the axis?
Madam, axis is around minus 75, madam. It's left X deviation.
So what do you think of that?
Maybe the patient was having some inlet VSD, which is called left X deviation.
Possible.
And 2-3 ABF are QF, so it's a clockwise rotation.
But one thing, you said tricuspid atresia. Having a tall R wave is against the tricuspid atresia.
Yes, madam. Yes, madam.
So how do you explain that? Because your first diagnosis was tricuspid atresia. So invariably tricuspid atresia axis is left axis.
But
and then RV forces are almost not there. And then LVH will be there.
Yes, madam.
So how do you explain this? Okay, Deepa is asking, the Q waves in V1 absent, the Q waves in V5, V6 present.
No, Q1 is V1 is present, V5, V6 is absent, madam. He's telling.
Where is the Q wave? I can't see that is the rhythm strip. See, what is significant is R wave is not increasing. Can you see that? There appears to be RV. Then when you come to V4, V5, V6, the height of R wave is not there. So what does it mean?
There is no progression of R waves, madam.
Why? Why there is no progression of the R wave?
That means the ventricular topology is not normal, madam. It's not a D-looped ventricle.
Either because of the repeated surgery, the position of the heart has changed, and that's why whatever the leads we are keeping in a normal position, we are not able to tap them properly. Or the LV forces, we thought, because apical impulse is heaving, and there is an ejection systolic murmur, and early diastolic, we all thought it is the aortic stenosis with aortic regurgitation. So with that, how can you not have the LV forces? That is a like $1 million question. How do you explain? Anyone? Anyone can put in a chat box?
Madam, it could have been the systemic ventricle could have been right ventricle, which is having the aortic stenosis, madam.
Okay. That means the right ventricle is pumping into the aorta.
Yes, madam.
And the left ventricle is pumping into the pulmonary artery.
Yes, madam.
And that's how it is. So somebody asked whether there is a weird discordance possible, and unbalanced AV canal defect of the RV dominance possible. So those are the things to be kept in mind as we go ahead. Okay? Agreed.
Yes, madam.
Okay. Show the X-ray now. Okay.
Yes, madam. Chest X-ray PA view, madam. Showing situs solitus, levocardia, normal exposure, slight leftward rotation.
Slightly overexposure because the vertebral column is seen.
Yes, sir. Yes, madam.
Okay.
Sternal wires are seen. There is no bony deformity, no obvious bony deformity.
Okay.
But vertebral column is also normal. CTR is around 50%, madam. Slightly rotated, so I cannot.
Cardiomegaly is not there.
Yes, madam.
Slight rotation is there.
Yes,
the
madam.
right atrium is not there.
Right atrium is not visible, madam.
Right atrium is not there. Right ventricle is also not there.
Yes, madam.
So what you're seeing is the left ventricle because apex is dipping into the diaphragm. And what is significant is the left atrial appendage is full.
Yes, madam.
Left atrial appendage is enlarged, but however, we are not seeing the double shadow of the left atrium. And the aortic knuckle is inconspicuous, and the pulmonary bay is not empty. So neither there is plethora nor oligemia. So what do you think of this?
Suppose, madam, adequate pulmonary blood flow, madam.
Okay. No cardiomegaly, adequate pulmonary flow, LV, LA are dilated.
Yes, madam.
Okay, that's what we can say. With this, does it fit into your diagnosis or no?
Yes, madam. In case of some aortic obstruction, there may be some LV hypertrophy, but there is not LA enlargement is also can occur, madam.
Okay. Okay, go ahead. Next. Show us the cat study.
Madam, echo first.
Echo first. Okay.
Yes, madam. Madam, this is the subcostal coronal view.
Okay.
Showing one of the diaphragm and spine, and two great vessels are either side of the spine. So it's
Okay. Put
and
the
the
color. This is pulsatile. So
yes, left side is pulsatile, so it's a situs solitus.
okay. The aorta is pulsatile and the thing. Okay. IVC appears to be slightly dilated. Okay. Then.
Yes,
Okay.
madam. This is the apical fourth chamber, madam. In the left side image, it's an apical fourth chamber showing one right-sided AV valve
Okay.
and one ventricle which is rough in which looks rough. So
Okay.
it may be.
You can see that here it is an atretic valve.
Yes, madam.
Okay, so this could be mitral, this could be tricuspid,
Tricuspid, madam.
because the pulmonary veins are draining here. So this is the left atrium and draining. So
Yes, madam.
previously we had discussed the case of mitral atresia. Now this is the tricuspid atresia. Okay, so there is a tricuspid atresia. Okay, then.
Madam, actually, the left side is showing one of the AV valve.
Okay.
And another valve is the outflow semilunar valve, which is opening, but the great vessel is ligated above that.
Yeah, you can see that the valve is in my. I think I'm not able to show my arrow. No, you show with the arrow. The semilunar valve is opening,
Yes,
and
madam.
above that there appears to be something binding there.
Yes, madam.
Okay, that's it. That's it. Is it
And
clear, everyone? See, this is one semilunar valve, and above that banding. And you are not going to put the banding in an aorta. So
yes,
it could be this is the pulmonary artery with the banding. Okay.
yes,
Then
madam, on the right side there is another
this is another
AV valve.
artery. Okay.
It's another AV valve which is opening into another ventricle, madam.
Okay. Now we'll put the color and then see. Go to the next.
Yes, madam. Yes, ma'am. There is this is the AV valve which is showing color Doppler evaluation, which shows mild AV valve regurgitation.
Okay.
And this is, madam.
But on auscultation, you did not get the pansystolic murmur.
Yes, madam.
So this is a mild one. It's a central jet and it is a mild one. Okay.
And this is maybe with a conduit, madam. This is the front conduit, but we are not seeing any blood flow from the conduit to the atrium.
We are not able to see the good amount of flow into the conduit.
Yes, madam.
So could it be obstruction at the conduit?
Maybe, madam.
Okay, that cannot be ruled out.
Yes, madam.
So could you think that the murmur could be arising from the conduit? Is it possible?
Madam, it will be if it is a conduit stenosis, then it will be a continuous murmur because it's a continuous flow.
Yeah, like the pulmonary artery stenosis, the conduit stenosis will be like a venous hum or a continuous murmur.
Yes, madam.
Okay. Go ahead. Next.
Yes, ma'am. This the left side of the image showing two outflow tracts, means two semilunar valves. The left sided semilunar valve is the aortic valve, and the right sided semilunar valve is the pulmonary valve. Which above that, the pulmonary artery is ligated.
Remember, the branching vessel is the pulmonary artery. Arching vessel is the aorta.
Yes,
and here the aorta is bigger. The pulmonary artery appears smaller because of the banding. The increased flow is prevented, and as a result, it is there. Now you can see the aortic regurgitation.
Yes, madam.
There is 1+ or almost grade 2, you can say.
Yes, madam.
But how do you grade the AR on the echo?
Madam, we can by visual eyeballing or by semi-quantitative method or by quantitative method, madam.
Okay.
Visual eyeballing by seeing the LV dilatation and ascending outer dilatation. Semi-quantitative by measuring the vena contracta and measuring the LV volumes.
Okay.
Quantitatively by measuring the
The
effective
ratio
regurgitation.
of the jet to the LVOT.
Yes, madam. LVOT to jet area ratio.
Vena contracta is more important. So
Yes,
how
madam.
much is the vena contracta in this?
Madam, 4 millimeter.
4 millimeter.
Yes, madam.
So how do you grade the AR or MR depending on the vena contracta?
Madam, less than 3 is vena contracta is mild.
Less than 3 is mild.
Yes, madam. 4 to 6 is
6 is moderate.
Yes, madam.
Anything above 7 is very severe.
Very severe, madam.
So here it is 4 means it is 1 plus.
Yes, madam.
Okay.
No,
Okay. The diagram clearly shows the AS-AR.
Yes, madam.
So this is the AR and this is the AS. You
Yes,
show
madam.
with your arrow.
The left side is the AS, madam.
Yes.
And the right side is the AR
Right.
jet.
Right. So how much is the gradient?
AS gradient is around 4 meter per second square, more than 4 meter per second, madam. So it will be more than 64 millimeters of mercury.
Around 60 to 64. Okay.
Yes,
So that means there is a significant aortic stenosis.
yes, madam.
But why it was not conducted to the carotid is a question.
Yes, madam.
So we did not see any membrane below the membrane. Is that? Can you see the membrane here?
Yes, madam. Here will see.
It is so clearly to see
Yes,
about
madam.
5 to 6 millimeter below. This is the, you show with your arrow that this is the aortic cusp and below that is the membrane.
Yes, madam. This is the aortic cusp, madam. Anterior aortic cusp.
Cusp.
This is the posterior aortic cusp, and this is the subaortic ridge like thing is there. Muscle bundle is there, madam.
Yeah. No, you don't use the word bundle. You use the word subaortic membrane.
Yes, madam.
There are 3 stages of subaortic membrane. A thin membrane could be there, or thick hypertrophy could be there, which is forming like a tunnel. And then that is the stage 3. So here this is like a stage 1 where there is a thin membrane is seen.
Yes, madam.
And someone who suspected subaortic membrane because the murmur was not conducted to the carotid. This signifies how clinical examination is important. Okay.
Yes, madam.
So valvar stenosis, you can see that there is no doming, there is no thickening, but there is an aortic regurgitation.
Yes, madam.
So the aortic regurgitation also is not very free because of the membrane. So membrane is preventing the flow of the regurgitation also. So clearly there is a subaortic membrane causing the stenosis, and that stenosis is causing the LV hypertrophy, apical impulse is there. And then there is an aortic regurgitation. That's why we get the early diastolic murmur in the herbs area. So without pH, PR, this is a AR. So
Yes,
clinical itself we suspected AS, that too subaortic membrane with the AR.
Yes,
Anybody has got any question? See, this is how we know when you analyze, when you have in your mind, you look for it. Otherwise, what happens is what your mind doesn't know, the eyes will not see. So this, you can visualize this. You can look in the apical 5-chamber view also and parasternal long axis view. Those are the best views for looking for the subaortic membrane. And subaortic membranes are progressive ones. Though the subaortic membranes are congenital, over the period, the membrane can become more. So probably when they did the surgery, it might not have been there or it might have progressed. One of the 2 things. Now, in the past few decades ago, we used to balloon dilate this membrane, but then we found that I have done a couple of them, but then it was not a good thing. The excision of the membrane is better to prevent the further damage to the aortic valve rather than the balloon dilatation. Okay, go ahead.
This is the short axis view of the aortic valve,
Okay,
showing both anterior right and anterior left, posterior left valve is moving nicely. There
okay,
is mild restriction of the right posterior valves, and it is little bit thickened, madam.
it is thickened and the commissures we are not sure, it may be fused, partially fused.
Yes, madam.
Now compared to the other commissures, you show with your this thing, it appears to be little thickened and little, and that thickening could be due to the subaortic membrane damaging it.
Yes,
That
ma'am.
could be the possibility, okay? Because it is known that any subaortic membrane can damage the aortic cusp. Okay, go ahead.
Madam, this is the Glen flows shown. There is a laminar flow across the SBC, and the flows are increasing during inspiration, madam.
Okay, that's a good demonstration. Okay.
Madam, he underwent cath in 6 months back, madam.
Till now, we have not, discussed the CAT data. I was thinking of having at least some of the CAT data discussion itself separately. But anyway, we'll decide here. Okay, show the CAT data.
Yes,
okay.
madam.
SVC?
Madam, this is a post Fontan, madam. So SBC, IBC, and Fontan conduit are having same pressures.
All will be having the same pressure and same saturation.
Yes, madam.
Okay.
And it's normal only 10.
Okay, 10 is okay. That is mean 10, is it?
Madam?
Mean, is it mean?
Mean, madam. All are mean,
Mean
madam.
10. So mean 10 is all right. Okay.
Yes, madam.
So there is no increased pressure.
Yes, madam.
Okay.
LPA mean pressure is 8. There is 2 millimeter gradient across from Fontan conduit to the LPA.
Okay.
And RPA has 9 millimeter.
2 millimeter gradient.
Yes, madam. LA mean pressure is 6. So there is a 4 millimeter transformer gradient.
Okay.
And as it is a single ventricle, univentricular palliation, so LV, RV has.
EDP 16. EDP 16 is high.
Yes, madam. EDP 16 is little higher, madam.
High. Okay.
Systolic pressure was, ventricular systolic pressure was 155. And ascending aortic pressure was 110, systolic was 110. So there was a 45 millimeter of gradient across the LVOT.
Okay.
And mean gradient of 40.
In the echo, you had got 64.
64.
And here you have got 50.
45. Yes, madam.
Sometimes what happens is when you are doing the CAT study, it depends on the heart rate also. While doing the echo, if the rate was more, the gradient will be more. Okay.
Yes, madam.
Okay, then Vaibhav is asking EDP 16 with the LA 6. How? Invariably, whatever EDP is there, that will be equal to the LA. Because it is a single ventricle, how do you explain, Ashish?
Madam, LA mean pressure has been taken EDP will be at the end of the diastolic pressure, madam. Mean will be, it's the average of the graph, area under the graphs, madam. So there will be some.
Okay. Okay, then.
Madam, this is the angiogram, madam. In the lateral view, madam.
You can put in the chat box your questions. This is the right heart catheter or the left heart catheter?
Madam, this is from the ventricle to the atrium to the ventricle. No, from the vena side to the atrium to the ventricle, madam.
This is a pigtail catheter.
Yes, madam.
Have you put it from the femoral vein or the femoral artery? I'm asking.
Femoral vein, madam.
Femoral vein. And that is the reason. So you have to say from the IVC, then into the RA.
Into the one of the atrium to the one ventricle, madam.
Okay.
And pictal tip is inside the ligated PA, madam.
Okay. So you can see that this is the RVOT. So
yes,
IVC, RA into the right ventricle and in the RVOT. So the pigtail is kept in the RVOT and this is the end. So literally it is like a pulmonary atresia, the iatrogenic. You have made pulmonary valve atretic by ligating it. And as a result, this is the blunt dilated RVOT. Is it clear? So this is the right heart catheterization. Using the pigtail catheter, there is a surgical wires are, sternal wires are seen. The IVC to RA, like an upper limb approach, it has been bent and taken into the RVOT. Okay?
Okay, madam. This is a pictal from same venous side, madam, into the RA into the RV.
Okay.
It is in the RV.
No, whether to call it as RV, okay, RV.
Yes, madam.
Okay.
And it is showing both the outflow tracks. One is atretic and another one is outer is filling from the RV, madam.
Now you are able to see RVOT, atretic, and your simultaneous filling of the aorta.
Aorta, madam.
And what is significant in the aorta here, it is aneurysmally dilated there.
Ascending aorta, madam.
The ascending aorta is aneurysmally dilated.
Yes,
Why
madam.
do you think it is aneurysmally dilated?
Because the whole of the cardiac output is going through the ascending aorta.
Okay.
And some AR is also there, so ascending aorta may be dilated.
Okay. So because of the subaortic membrane and the aortic regurgitation, and it's almost like a single ventricle physiology. And since REOT is atretic, that means it is blunt. The whole blood is going, the systemic venous as well as the pulmonary venous blood, everything is going into the aorta. So the aorta is dilated. Okay?
Yes, madam.
Okay. And also there is some amount of AR.
Yes, madam.
Okay. Go ahead.
This is the pictal through the descending aorta, femoral artery to descending aorta to the ascending aorta and the aortic root.
Left heart catheter, the pigtail from the femoral artery, descending aorta into the ascending aorta.
Yes, madam.
And you tell the which view. Is it a AP view?
It's a RAO view, madam.
RAO view. RAO with the cranial angulation or no?
Yes, madam. Cranial angulation, madam.
Invariably, if you want to show the cephalic vessels, we give the cranial angulation. Otherwise, we give the caudal. So this is the cranial angulation. And here you can see that the annulus is dilated and there is a grade
Moderate AR.
1 plus, that's all. Okay.
Yes, madam.
The AR is not very significant. It is just 1 plus. And echo also we thought it was 1 plus.
Yes, madam.
Now, how do you grade the AR angiographically?
Madam, grade AR in?
Okay.
No, madam, I didn't hear, madam, question.
No, angiographically, how do you grade the AR? See, echocardiographically, we discussed how the AR is graded.
Yes, madam.
Contracta and by the grade, the ratio of the LVOT to the jet. But here, how do you decide? Anyone?
Madam, the amount of contrast which is regurgitating back to the LV and
See, if the dye that comes into LV, it is cleared within the next 1 or 2 cycles, it is mild. So here you can see that it is cleared with the very next cycle.
Yes, madam.
Okay. So contrast coming in the in cardiac cycle. See then, immediately very next cycle it is cleared. That means it is a mild one. If it persists despite 2-3 cycles, it is very severe. In a severe AR, the whole LV will be filled and it will not clear in the next 2-3 cycles. So in between is the moderate. So this is a mild one. Okay. Go to the next.
Madam, finish.
Next.
Finish, madam. This much is, madam.
At the end. Okay. The CT.
Yes, madam. CT also.
So here we can say that it is the cyanotic congenital heart disease, situs solitis, with the tricuspid atresia, with the pulmonary banding, with the subaortic membrane, with the AS and AR. The subaortic membrane causes stenosis and mild AR.
Yes,
And
madam.
we have seen the conduit, and then the Glen also we have seen.
Yes, madam.
Okay. So that's what we have concluded. What extra point will you get by the CT now?
Madam, the exact location of the obstruction, location of the obstruction and the mechanism of obstruction also we can know.
See, pulmonary vascular branching and the conduits, all of them can be better seen in the CT rather than the echo.
Mhm.
Okay. Okay, go ahead. Okay, read. The ventricle appears like a trabeculated, no?
Yes, madam. Madam, there are. This is the LA, madam.
Huh? Okay.
Madam, here the ventricles are superior, inferior, madam.
Okay, okay. Okay. So what is the report of the CT?
Madam, there is a crisscross ventricular connection, atrioventricular connection, madam,
Okay.
with some
Yes,
subaortic of
crisscross
subaortic.
ventricles is difficult to make out in the echo, but of course we can make out, but the CT is better. So
Yes, madam.
crisscross ventricle, is it congenital or it is because of the maneuvering during the surgery?
Madam, it is congenital, madam.
Okay, fine. Okay, fine. Great.
Mm.
Now, in this side, you can see the crisscross ventricle, you know.
Yes, madam. Yes, madam. This is the inferior ventricle and this is the superior ventricle.
Show with your thing to the viewers. Okay.
Yes, madam. This is the lower one is the inferior ventricle, and the superior one is actually right ventricle, little bit trabeculated, and that is giving the aorta, madam.
Yeah.
And there is a discrete membrane below the aortic
See
valve,
the
madam.
membrane. So we thought it is a very thin one in the echo, but here you can see that the filling defect is so much. So it's
Yes,
a thick subaortic membrane is there. Okay.
Yes, madam.
Okay, then.
And the ascending aorta measures around 40 millimeter, madam. So not much dilated.
Okay.
And the fontan is functioning well, madam. There is nothing, no problem.
Fontan is functioning well.
Yes, madam.
Now the main problem is subaortic membrane causing obstruction and the aortic regurgitation.
Yes, madam.
Otherwise, whatever the surgical correction has been done is fine. So now his exertional dyspnea that he has come is because of the demand to supply mismatch caused by the subaortic obstruction. Okay,
Yes, madam. Yes, madam.
that's the functional conclusion that we make. So would you like to make a final diagnosis now?
Yes, madam. He's having congenital cyanotic heart disease. Initially, to have increased pulmonary blood flow, palliated at 3 months of age with PA bending,
Pulmonary banding.
followed by at 1 year of age of bidirectional right-sided Glen, and then followed by at 11 years of age extracardiac fenestrated fontan.
Okay.
Then he developed, now he is having severe subaortic stenosis.
That acyanotic congenital heart disease. with the situs solitus,
Yes, madam.
tricuspid atresia with the pulmonary banding, and then subaortic membrane causing subaortic stenosis and aortic regurgitation, and the functioning bidirectional shunt and the conduit obstruction along with the crisscross heart.
Yes, madam.
Okay, sinus rhythm, no bacterial endocarditis, and LV function is normal. That is our final diagnosis. Any questions? If there are no questions, I think Ashish has done well by presenting such a complex case so well. And in the examination, you should not give directly the what to say, here you know what it is, but in the examination you should not. You should give the possibilities 1, 2, 3. So like how you did the 2, 3 possibilities, and then gradually you have to improve. See, almost 50% we know what it is complex in the history, and with the clinical examination we know it is a complex one. With the echo we have almost a final diagnosis. Only extra thing that we could make out apart from the angio in the CT is crisscross heart. Otherwise, all the rest of the findings were made with the echo and the angio. Okay.
Yes, madam.
So, how do you think you are going to manage next?
Madam, as the AS is severe, so resection of the
You have got 64, no? I mean,
Yes, ma'am.
64 on the echo and 45 in the thing.
cath.
So, 45 is not much. But one thing you must explain to the patient that subaortic membrane is a progressive
Progressive
condition
disease.
and it is likely to increase. And then when it goes to the almost like a tunnel, the surgery becomes very difficult. So an elective subaortic membrane resection or excision can be advised to the patient.
Yes, madam.
Is it okay? Okay. If there are no questions in the chat box, there are no questions. That means everybody has learned a lot from this case. And I thank Shiva for giving such a good case for the discussion. And thank Ashish for presenting so well. And also thank the whole audience like Jishan, then Vaibhav, Sangamesh, and also Rohit for contributing so well to the discussion. So thank you very much. Good night.
Good night, madam. Thank you, madam.